I am now going to introduce our first speaker, and it gives me great pleasure in introducing a close colleague at the Brigham and Women's Hospital. He's widely considered to be an expert in acute kidney injury research and clinical practice. David Leaf is associate professor of medicine at Harvard Medical School. He's a renal physician at the Brigham and Women's Hospital, where he did his training. He runs a research laboratory that is widely considered not only to be great expertise in acute kidney injury research, but also involved in writing guidelines and in clinical practice. So thank you again, David, for coming in on a Sunday morning.
Okay, good morning, everyone. Thanks for being here. Thank you, Ajay, for the introduction. It's nice to see so many familiar faces from last year. Just kidding. No, of course, everyone will pass the boards. If you stay awake the whole time, you will pass. So AKI always goes first, I think probably because there's wide recognition that this is the single most interesting and important topic in all of internal medicine. So I'm very happy to be here. I really need to update this picture. This is about 10 years old. I am going to do it this year. I'm going to do it. But this is a little bit about me. As Ajay mentioned, AKI is sort of what I live and breathe. I do clinical trials in this area and epi research, and let's get right into it. These are some of my disclosures, none of which are relevant to the talk. And these are some key learning objectives, including the diagnostic approach to AKI, as well as management. This is a new requirement this year, a mock reflective statement. I guess this is like take-home points. So in approaching the differential diagnosis for AKI, consider pre-renal, intrinsic, and post-renal causes. Of course, we will talk more about all of that. And order diagnostic tests based on clinical suspicion. Know the diagnoses associated with common urinalysis and urine sediment findings. Those tend to be very common questions that on the boards. They'll give you a urine sediment finding, and usually that alone will give you the answer. Know the treatment for AKI in specific clinical scenarios. We'll talk about that. And we'll also talk about the findings from several large recent RCTs in AKI. Here's an outline of the talk. We'll go through the epi briefly, nomenclature, definitions, physiologic classification, diagnostic approach, management. We'll talk about some recent large RCTs, and we'll conclude with 2 board-style questions. So just one slide on epi. AKI is common, as you know. It occurs in roughly 10% of hospitalized patients and up to 50% of ICU patients, depending on how you define it. It costs over $10 billion annually in the US alone. Patients who develop AKI are at greatly increased risk of in-hospital death, and those who survive have an increased risk of chronic kidney disease, end-stage kidney disease, and cardiovascular events like MI and stroke. Therapies that reliably prevent or treat AKI are lacking in most cases. A quick word about nomenclature. So anyone here who went to medical school more than about 10 years ago probably would have learned this as acute renal failure, or ARF. Nobody actually says ARF, but the name got changed to acute kidney injury about 10 years ago. Acute remained, and acute, of course, implies that this is something happening within hours to days. Kidney is more familiar to patients than renal, so there has been a push across the board to get rid of the word renal and use kidney, so end-stage kidney disease now instead of end-stage renal disease. And injury instead of failure, because injury refers to organ damage, whereas failure really implies the need for dialysis. And of course, not everyone with AKI requires dialysis. Historically, there have been various attempts to define AKI. This is primarily for research purposes, so that people who are publishing on AKI have consistent definitions. In 2004, we had the rifle criteria. A couple years later, it was updated to the Akin criteria. And in 2012, we had the KDIGO definition, and this remains the current definition of AKI. I don't think that they would ask this on the internal medicine boards. It's really more useful for research than for clinical practice, but just in case, the definition is there. So basically, an increase in serum creatinine of at least 0.3 in 48 hours, or at least 50% in 7 days, oliguria, or dialysis. Now, again, from a research standpoint, you can go even farther and you can stage AKI, and there's staging based on serum creatinine, there's staging based on urine output, and you see I've got a big X through it because I don't want you guys to memorize that. And my mentor, Sus Weicker, I think said it best in an editorial in 2019 when he said, on rounds, when a medical student presents a case of AKI, the focus may turn to the KDIGO sanctioned stage. Is it 1A or is it 1B? Or could it even be stage 2? We then have less time to argue over why the creatinine is increased in the first place, which is of course the most important thing. We want to know what's the etiology of the AKI, not, was it stage 1 or stage 2? So in terms of etiology, we can think about etiology in terms of the classic physiologic classification, pre-renal, intrinsic renal, and post-renal, and we'll talk about that. Or we can think about it in terms of what is the clinical setting in which this is occurring. And some of the most common settings are sepsis and critical illness, cardiac surgery, and nephrotoxins. And nephrotoxins can be broken down into exogenous or endogenous. Common exogenous nephrotoxins include chemotherapy, like cisplatin or methotrexate, and now increasingly immunotherapy, antibiotics, NSAIDs, IV contrast, and then endogenous nephrotoxins include things like myoglobin from rhabdomyolysis, hemoglobin from microangiopathic hemolytic anemia, and uric acid from tumor lysis syndrome. Now, whether you're a medical student, resident, renal fellow, or renal attending, we still think about AKI using this classic approach. And we ask ourselves, which of these 3 buckets is the patient most likely in? So pre-renal azotemia, you'll notice I have the word AKI crossed out, and that's because with pre-renal azotemia, there is no structural injury to the kidneys. The serum creatinine increases due to renal hypoperfusion, and when you restore the hemodynamics, oftentimes just by giving IV fluid, you see rapid recovery of kidney function. Etiologies of pre-renal azotemia include true volume depletion, and this can be seen, for example, with patients with a lot of GI loss from diarrhea or from vomiting or hemorrhage. Decreased effective arterial blood volume, like CHF or hepatorenal syndrome. These are conditions where you often have total body volume overload, but you're intravascularly dry. And then impaired renal hemodynamics. And this can be seen commonly with NSAIDs, which lead to afferent vasoconstriction, or with ACEs and ARBs, which leads to efferent vasodilation. Intrinsic renal disease is the most complicated. And this slide, as busy as it is not a comprehensive list of all of the intrinsic causes. These are just some of the more common causes. When we think about intrinsic renal disease, we usually like to start by thinking which part of the nephron is involved. Is it the small vessels, the large vessels, the interstitium, or the tubules? Tubular injury tends to be by far the most common, and it comes in 2 flavors: acute tubular necrosis, or ATN, and obstruction. Common causes of ATN include ischemia and sepsis. Think about your patient in the ICU on multiple pressors, for example. Endogenous toxins, like we talked about, rhabdo, hemolysis, and exogenous toxins. Obstruction can be caused by things like paraproteins in myeloma, uric acid with TLS, tumor lysis syndrome, and certain drugs, which can crystallize and obstruct the tubular lumen. When we think about interstitial disease, there are a lot of different things that can cause this, but the most common tends to be acute interstitial nephritis, or AIN. We can have disorders affecting the large vessels, like renal vein thrombosis or abdominal compartment syndrome, and finally we can have things that affect the small vessels, like glomerulonephritis, TTP, DIC. My group actually just published a paper recently looking at platelet factor 4, so patients with HIT, and finding that they have an increased risk of AKI as well, probably because there's some microvascular thrombosis occurring in the kidneys. Post-renal is pretty simple. It's basically just a plumbing problem. And the diagnostic and imaging workup is either to simply insert a Foley catheter or obtain a bladder scan. And in terms of imaging, renal ultrasound or CT. However, importantly, not every patient with AKI needs a renal ultrasound. I think this is a misconception. The utility is heavily dependent on the pretest probability. So your patient in the ICU on 2 or 3 pressors does not need a renal ultrasound. Someone coming into the ER with advanced ovarian cancer with an AKI does need a renal ultrasound. So you have to look at what's going on. And a pearl is that early in the course of obstruction, beware of false negatives on imaging. So if you get an ultrasound early on, it may be negative or it may only show mild hydro, but it's going to be mild before it's moderate, and it's going to be moderate before it's severe. So there can be a lag. Studies to consider ordering, again, depend on the clinical context. One exception to that would probably be a urinalysis and a urine sediment. One could argue that every patient with AKI needs those 2 tests at a minimum. But other tests really depend on the context. You can sometimes get a urine sodium to calculate a FeNO. Blood tests are shown here. I won't read all of this to you, but depending on the disorder you're worried about, these are the blood tests that you would think about ordering. And we talked about radiographic tests. Now, these are some pearls regarding the urinalysis and AKI. When you see blood on urinalysis, but no RBCs in the urine sediment, you should think about either rhabdomyolysis or hemolysis. And the reason is because the urine dipstick is not actually detecting blood, and that's why I have blood in quotation marks. It's detecting heme. And so if there is heme in the urine, but there are no, when you look under a microscope, which is the sediment, you don't see any intact red blood cells, then that means that could only mean one of 2 things. There's heme that's being detected from myoglobin, as is seen with rhabdomyolysis, or it's free heme from hemolysis. Protein on urinalysis only detects albumin, and therefore you can miss other causes of proteinuria, such as paraprotein disorders from multiple myeloma, and normal glycemic glucosuria. So your glucose in the blood is normal, but you've got glucose in the urine. And this is a telltale sign that there is some proximal tubular dysfunction, also known as Fanconi syndrome. And common drugs that can cause this include tenofovir, ifosfamide, cisplatin. Myeloma is not a drug, but myeloma can certainly cause this. And then there's a much more common class of drugs, of course, that we now use, which is the SGLT2 inhibitors, which will do this as well. Well, obviously, in that case, it's not pathologic. That's how the drugs work. But you will see glucose in the urine in those patients. So here, on the left side, we have the UA/urine sediment finding, and on the right side, we have the diagnosis. Obviously, in real life, it's more complicated than this. We know that we have to take urinalysis and urine sediment findings with a grain of salt. But for the boards, I think it's a fair bet that if you see the thing on the left, the diagnosis on the right is what you should be thinking about. So we already talked about the first one, but you've got 3+ hematuria on urinalysis, but negative or just trace RBCs on the sediment. You should think about rhabdo or hemolysis. 3+ protein on urinalysis, lots of RBCs and lots of WBCs, glomerulonephritis. Muddy brown cast, think about ATN. Sterile pyuria, think about AIN. Oxalate crystals, you should be thinking about ethylene glycol toxicity. And a bland urine sediment can be seen in a number of different disorders, ranging from pre-renal azotemia to cardiorenal syndrome to hepatorenal syndrome and others. I mentioned the FeNO briefly. So, FeNO is one of those tests that's very popular among the house staff. And the traditional teaching is that if you have a FeNO less than 1%, you should be thinking pre-renal, and that if it's greater than 2%, you should be thinking about ATN. But that is an oversimplification because the FeNO can be misleading in certain situations. And a low FeNO does not necessarily mean give IV fluid. And so what are those situations? So there are scenarios where you can have a low FeNO that's misleading. So patients with glomerulonephritis, rhabdo, and IV contrast nephropathy, all of those patients will have a low FeNO, but it doesn't necessarily mean that they are volume depleted. In many of these cases, the low FeNO is being caused by renal afferent arteriolar vasoconstriction. So the kidneys are being tricked into thinking that they're in a pre-renal state, and so they hang on to sodium, but it doesn't mean that they actually are pre-renal. And then on the flip side, there can be things that cause a high FeNO, but again, it doesn't mean you have ATN. Diuretics and chronic kidney disease will give you a FeNO greater than 2%, but that doesn't really tell you anything in those situations. Okay, now here we have six AKI etiologies on the left, and then we have the treatment in the middle, and then we have a clinical pearl on the right. So with rhabdomyolysis, the treatment is IV fluids and possibly urinary alkalinization. I say possibly because it used to be more common. It's sort of fallen out of favor. Of course, the idea is that by alkalinizing the urine, the myoglobin will be more soluble. It's part of the reason it's fallen out of favor is because when people do alkalinize the urine, which is usually done by giving a sodium bicarb drip, they forget to watch out for the predictable electrolyte abnormalities that will occur with bicarb. And those are hypocalcemia, and it's really the ionized calcium, not the total calcium, that will drop. And that's because the calcium is being shifted onto albumin, and hypokalemia. With tumor lysis syndrome, the treatment is IV fluid and rasburicase. But a clinical pearl here is that AKI itself will raise the uric acid level because we need the kidneys to get rid of uric acid. So not every patient with AKI and hyperuricemia needs rasburicase. It's a very expensive medication. It should really only be given to patients with active hematologic malignancy with real TLS. Rarely patients with solid tumors can have TLS as well. With CHF, the treatment is, of course, diuresis, usually with a loop diuretic. And the clinical pearl here is that a mild increase in the serum creatinine does not mean that you need to necessarily back off on diuresing. It may simply be that you're actually effectively diuresing the patient, and the blood is now somewhat hemoconcentrated, so the creatinine is going up for that reason. It doesn't necessarily even reflect true kidney injury. With acute interstitial nephritis, the treatment is, of course, to discontinue the offending agent and treatment with steroids, although there's never been a placebo-controlled trial showing that steroids are effective for AIN, and there probably never will be. But that's just what we do based on observational data. The pearl here is that fewer than 10% of patients will have that classic triad that you learned about in medical school of fever, rash, and eosinophilia. So the absence of these features certainly does not rule out AIN. In fact, 90% of patients will not have the triad. With anti-glomerular basement membrane disease, the treatment is the kitchen sink, plasmapheresis, cytoxan, and steroids. And an interesting clinical pearl here is that pulmonary involvement is rare unless the patient is a smoker or they have some other underlying lung disease. And the thinking here is that there needs to be some damage to the endothelium in the lungs for the antigen to see for the antibody to see its antigen expressed by the basement membrane. And with ischemic acute tubular necrosis, which is of course, one of the most common causes of AKI we see, the treatment is unfortunately just supportive. We don't have any therapies for this other than dialysis when it becomes severe. Indications for dialysis in AKI, AEIOU is a good, easy way to remember this. Acidosis, electrolytes, primarily hyperkalemia, certain ingestions, overload, and uremia. Dialysis modality in AKI. So when do we think that a continuous modality like CVVH is more beneficial to the patient than intermittent hemodialysis? So the first thing that usually comes to mind is hemodynamic instability, patients who are on multipressor shock, but also patients with a large daily obligate fluid intake. And these are patients who we just can't keep up with every other day hemodialysis because they're getting 5-6 liters a day of fluid and they need continuous therapy. Traumatic brain injury, where there's concern for herniation, and fulminant hepatic failure. These are conditions where we just think that the continuous therapy is more gentle and is less likely to exacerbate these severe underlying injuries. Okay, so very briefly, we're going to talk about 4 important RCTs, each of which was published in the New England Journal in the last roughly 5 years, and all of them, of course, on AKI. The PRESERVE trial was a trial that enrolled roughly 5,000 patients undergoing coronary or non-coronary angiography. This is one of the largest AKI trials that's ever been done. Patients were randomized in a 2x2 factorial design to either bicarb versus saline and to N-acetylcysteine versus placebo. The primary endpoint was a composite of death, dialysis, or persistent kidney function decline, and there was no effect of either intervention on the primary outcome. So the takeaway from this is that we still think that IV fluid is helpful in preventing contrast nephropathy in high-risk patients, but it doesn't matter if you give bicarb versus saline. So now we pretty much just give saline. The PLUS trial, speaking about bicarb, so the PLUS trial also enrolled about 5,000 patients. These were all critically ill patients who were randomized to either normal saline versus what's known as a balanced solution. You've probably heard of solutions like lactated ringers. Which is basically a balanced solution. Here they happen to use something called Plasmolite, but similar concept. The idea is that these are solutions that have more physiologic concentrations of sodium and chloride as compared to normal saline. The primary endpoint was 90-day mortality. Secondary endpoints looked at AKI, and there was no effect on the primary outcome. You can see the Kaplan-Meier curve here. The curves are essentially entirely overlapping. And if you're still not convinced, NEJM Evidence published a systematic review with meta-analysis of 13 RCTs looking at normal saline versus balanced solution. These RCTs included over 35,000 critically ill adults that were randomized to one intervention or the other, and there was no difference in 90-day mortality or risk of AKI. So feel free to just give normal saline. The START AKI trial enrolled 3,000 critically ill patients with AKI, and they randomized them to an accelerated RRT strategy versus a standard strategy. The idea being that perhaps starting patients on dialysis earlier may be beneficial. So the accelerated strategy basically initiated patients within 12 hours of meeting certain criteria, like volume overload or certain electrolyte abnormalities, whereas the standard strategy was basically waiting until they had a hard clinical indication for dialysis, a life-threatening indication. And there was no effect of accelerated RRT on mortality. And I would say this has really changed practice. We often point to this trial as a reason not to start dialysis early and to wait for a clinical indication to develop, because some of these patients may improve on their own and they may not need dialysis. Okay, so that was kind of depressing. Three negative RCTs. So here's the fourth one, the CONFIRM trial. Much smaller, 300 patients. These were patients with hepatorenal syndrome, and they were randomized 2-to-1 to terlipressin versus placebo. Terlipressin is kind of like vasopressin, but you don't need to be in the ICU to receive terlipressin. It's not a continuous infusion. It's given every 6 hours or so. In both groups, albumin is strongly encouraged. The primary endpoint was reversal of HRS. And HRS reversal occurred in 32% of the terlipressin group as compared to 17% in the placebo group. Highly statistically significant, right? Nearly a doubling of the rate of HRS reversal. Now, there was one little problem with which was there was a trend toward increased risk of death in the terlipressin group. But it was non-significant, but nonetheless, it was there. And it was almost entirely driven by respiratory death. And so the take-home there is that we use terlipressin in some patients with HRS, but if they have any concern for respiratory dysfunction, then we avoid it. So here's a summary of those key findings from those 4 recent RCTs. The PRESERVE trial found no benefit of bicarb versus saline and no benefit of NAC versus placebo. The PLUS trial found no benefit with balanced crystalloid versus normal saline. The START AKI trial found no benefit with accelerated versus standard initiation of RRT. And the CONFIRM trial did find a benefit with terlipressin in HRS. So we're going to conclude with 2 board-style questions, and I think it's interactive. So the first question is a 70-year-old, by the way, this is a real patient that I took care of, I'll mention. A 70-year-old man with metastatic melanoma presents to oncology clinic. He reports several episodes of non-bloody diarrhea during the past 2 weeks. Labs show serum creatinine of 6.5, up from his baseline of 1.2. He reports staying well hydrated by drinking Gatorade. He has been receiving treatment with ipilimumab and nivolumab, or ipi-nivo, as the oncologists say. And his most recent treatment was 3 weeks ago. Urine protein creatinine ratio is 0.5. Renal ultrasound is negative. Which of the following is the most likely thing to be seen on kidney biopsy? I'll give you guys a minute to respond. Okay, wow, 100, you guys can't see this, I don't think, but I can see it. Oh, never mind. Initially it said 100%, said answer C, but it keeps changing. So about 70% of wow, it's still changing. That's so funny. Say about half to 70% of you got the answer correct, which was answer C, acute interstitial nephritis. And this was AIN from the immune checkpoint inhibitor. So immune checkpoint inhibitors, as I'm sure most of you know, I'm sure you've encountered these drugs on the wards, are a novel class of monoclonal antibodies that target inhibitory receptors on T cells, other immune cells, and tumor cells. I don't even know if we can keep calling them novel because they've been around now since 2011. And they've really revolutionized oncology. So I suspect you will hear about immune checkpoint inhibitors throughout this course. The Nobel Prize in medicine was given to James Allison at MD Anderson for his work that led to the discovery of the immune checkpoint inhibitors. And what James Allison said was what we needed to do was to release the brakes of the immune system to fight cancer. And this is how it works. These drugs, these monoclonal antibodies basically block inhibitory receptors on T cells. So if you block the inhibitory receptor, that allows the T cells to have unopposed activation to then go and fight the cancer cells. On the left, these are some of the first immune checkpoint inhibitors that were FDA approved: ipilimumab, nivolumab, pembrolizumab. You've probably seen commercials on TV for Opdivo, which is pembrolizumab. And now we have roughly a dozen FDA approved immune checkpoint inhibitors. Immune checkpoint inhibitors, as great as they are, though, can cause a unique spectrum of autoimmune toxicities, so-called immune-related adverse events. And these can affect virtually any organ in the body, including the kidneys. Now, the kidneys are not affected as commonly as some of the other organs. So the skin and the GI tract tend to be the most common. But the kidneys certainly can be involved. My lab actually did much of the original work describing kidney involvement in patients with immune checkpoint inhibitor-associated AKI. And the most common pathophysiology when you biopsy these patients is AIN. It's seen in over 90% of patients. And these patients have a similar presentation to other causes of AIN. So they have pyuria, they have mild to moderate proteinuria, so-called tubular proteinuria, although it's really nonspecific. You can't count on those urinary findings to make the diagnosis. Extrarenal IRAEs are frequent. And actually, in the blurb that I gave you, in the clinical synopsis, I mentioned that the patient had diarrhea, which is supposed to be the clue that the patient had immune checkpoint inhibitor-associated colitis. So colitis, rash, thyroiditis, and other endocrinopathies. One interesting thing with this entity, as compared to AIN that you see from other drugs, is that it can have a delayed onset. So with antibiotics or other medications, if you're going to have AIN, it typically presents in the first few days or weeks. But with immune checkpoint inhibitors, it can be delayed by several months. There have even been patients who have had it a year later. And the treatment is glucocorticoids, and most patients respond well to that. Second question. A 66-year-old man, previously healthy, is admitted to the hospital with chest pain. Vital signs on admission: BP 126/78, heart rate 102. ECG reveals ST segment elevation in the inferior leads. He's treated with aspirin, heparin, metoprolol, and nitroglycerin, and taken to the cath lab, where he undergoes successful PCI of an occluded right circumflex artery. During the procedure, the blood pressure was stable, but the serum creatinine, which was 0.7 on admission, is already up to 1.4 by hospital day 3, and it's up to 7.8 by hospital day 9. And on exam, you see this. So the question is, the part of the kidneys most likely to be involved in the pathophysiology is what? Okay, so kind of a mix here, but the most common answer was A, with about half of you answering that way, and that is correct. The afferent arterioles and the glomeruli. And this is renal atherosclerosis. Angiography is the most common triggering event, but even just anticoagulating a patient can also be a risk factor. You basically break up all those crispy crunchies in the aorta, and then they go and shower downstream. The clinical course is variable, and it includes subacute kidney injury, which can occur weeks later, or as in the patient here, it can be more severe and sudden AKI. And the physical exam findings include livedo reticularis, which is shown here, as well as blue toes. Urinary findings are nonspecific, but you may see eosinophilia and hypocomplementemia. And the pathophys is that there are cholesterol crystals that are lodged in the small arteries throughout the body, but primarily in the kidneys. And the treatment is supportive. These are some references that I referred to, and there's my email address. Feel free to contact me anytime. Thank you very much.